Welcome to The Funnel Effect. Today's deep dive is based on the review topic, Cardiac Sarcoidosis by David H. Burney, Pablo Bineri, Andrew C. Ha, and Rob S.B. Beanlands, published in the Journal of the American College of Cardiology. It's JACC, volume 68, number 4, back in 2016. So we are jumping into what I think is one of the trickiest clinical challenges in cardiology. It's this inflammatory disease that often hides in plain sight, but it carries this disproportionately high and sometimes fatal risk. We're talking about sarcoidosis. The source defines it as a multisystem granulomatous disease, and the cause, still unknown. Now, usually when people hear sarcoidosis, they think lungs, and that makes sense. The lungs are affected in, over 90% of patients?
That's right, the vast majority. But our focus today, cardiac sarcoidosis, or CS, well, that's critical because when this inflammation decides to target the heart, it becomes a completely different beast. Much more serious, often harder to pin down.
Right, and that's the core tension here, isn't it? This deep dive is all about that tension.
Exactly. You see, clinically manifest CS, the kind that actually causes symptoms people notice, might only show up in about 5% of people with systemic sarcoidosis.
Only 5%. That sounds deceptively low.
It is deceptively low because CS is often the most serious, the most life-threatening part of the disease. And what really makes this urgent, what we really need to get a handle on, is the huge amount of hidden prevalence.
The unseen danger lurking beneath the surface kind of thing.
Precisely. The authors estimate that somewhere between 20% and 25%, maybe even 1 in 4 patients who have confirmed sarcoidosis in their lungs or elsewhere, they also have asymptomatic cardiac involvement.
Wow. Asymptomatic. So clinically silent.
Clinically silent. Think about that. 1 in 4 people walking around with sarcoidosis might have this potentially deadly damage happening inside their heart muscle, and they feel fine. Damage we can only find if we actually go looking for it with the right tools.
Okay.
And this realization that the disease is so often silent, well, that's what really spurred the creation of those 2014 international guidelines. And it's what drives our mission today.
Got it. So our mission today is to really cut through the complexity of this hidden inflammatory threat. We're going to unpack the main ways it shows up, the key diagnostic tools, especially the imaging that lets us see the scar and the active inflammation, and finally, how those guidelines tell us to manage it, even though, as we'll see, there isn't always that gold standard trial evidence we'd like. Let's unpack this. Okay, so before we dive deep into the hard stuff, let's talk about sarcoidosis more generally. At a basic level, what's happening, even if we don't know the exact trigger.
Right. The etiology, the ultimate cause, is still officially listed as unknown. That's a key part of the definition. But the working theory, the accumulating evidence, points towards an immune system overreaction.
An overreaction.
Yeah, basically, in someone who's genetically susceptible, their immune system seems to mistake some unidentified trigger, maybe an environmental antigen, maybe something infectious, we just don't know, for a dangerous invader. And it mounts this really aggressive response.
And the result of that immune response is?
The histological hallmark. These things called non-caseating granulomas. Tiny, organized clusters of inflammatory cells.
Granulomas. And these clusters, they're the troublemakers, right? They form where they shouldn't, and they mess up the normal tissue.
Exactly. They disrupt the normal architecture. And you can imagine in the heart, that disruption can be absolutely catastrophic. Granuloma in the lung might just make it a bit harder to breathe, but put that same granuloma right on the heart's electrical highway, that could cause sudden death.
That really puts it in perspective. What about who gets this? Demographics.
Yeah, the disease tends to hit people in their prime, mostly between 25 and 60 years old. It's pretty rare in kids under 15 or adults over 70.
Right.
And prevalence varies wildly across the globe. It seems to be highest in Northern Europeans and also African Americans. Rates can range dramatically, maybe 4 or 5 per 100,000 in some places, up to over 60 per 100,000 in others. And in those high prevalence groups, it often affects women more frequently.
The source also mentioned a strong genetic link, like it runs in families sometimes. But you mentioned something fascinating, that the genes might even influence where the disease shows up.
Yes, that's a really interesting angle. It's not just about being generally susceptible to sarcoidosis. Some genetic factors seem to be linked to, organ tropism, a preference for one organ over another.
Like the disease has favored targets based on your genes.
Sort of. The authors point to specific gene associations like HLA-DQB0601 or an allele of tumor necrosis factor called TNFA2, What's really striking is that these specific markers were described in Japanese patients who had cardiac sarcoidosis specifically.
Ah, so not just general sarcoidosis, but heart involvement in particular.
Exactly. It strongly suggests that having certain genetic markers might make it more likely that if you do get sarcoidosis, those granulomas are going to end up in your heart muscle, not just, say, your skin or lungs.
That distinction feels really important. It almost implies that if someone has systemic sarcoidosis and belongs to a high-risk genetic group, maybe a cardiac workup should be standard.
It certainly raises that question, doesn't it? And this leads us right into one of the most compelling points in the review. This idea that CS seems to be becoming more prevalent. It feels like it's suddenly everywhere.
But is it really? Or are we just getting better at finding it?
The evidence strongly suggests the latter. It's likely not a true epidemic. It's more of a, well, technological revelation.
Like that data point from Finland you mentioned earlier.
Exactly. A 20-fold increase in the diagnosis rate between 1988 and 2012. That's just staggering.
Yeah.
That kind of jump doesn't usually happen because a disease suddenly explodes. It points directly to improvements in our diagnostic tools, especially advanced imaging like cardiac MRI and PT scans. We'll definitely dig into those later. They've basically lifted the veil on a problem that was probably there all along, just hidden.
And uncovering that hidden problem revealed something else quite shocking, that CS can be the first sign of sarcoidosis, sometimes the only sign.
Yes, that's a huge paradigm shift. The source says up to a third, maybe 30% of clinically manifest CS cases are what they call isolated CS. These people don't have the typical lung findings or other systemic signs.
The heart problem is the debut.
It is the debut. This completely changes how clinicians need to think. You can't wait for lung problems to show up before you consider cardiac sarcoidosis. The heart issue itself might be the very first clue.
So as a cardiologist, you have to keep sarcoidosis on your differential list, even if the patient looks systemically healthy otherwise. Which brings us to that, frankly, astonishing statistic about misdiagnoses.
It really is a wake-up call, especially for anyone working in cardiac electrophysiology dealing with heart rhythm problems.
Right.
When you look at specific groups of patients presenting with really serious unexplained electrical issues, think complete heart block in younger folks, say under 60, or ventricular tachycardia, VT, where you can't find a cause like a prior heart attack.
Yeah.
It turns out that a significant chunk of these patients, somewhere between 16% and maybe even 35%, actually have underlying previously undiagnosed cardiac sarcoidosis.
16 to 35%. That's
Oh,
huge.
that's massive. It means if you see unexplained VT or high-grade heart block in a relatively young person, you are potentially failing that patient if you don't actively and aggressively rule out CS. The cardiac symptoms aren't just a side effect, they're often the first, loudest alarm bell ringing.
Okay, so let's focus now on when CS is clinically manifest, when it's bad enough to cause symptoms. The source talks about a principal trio of manifestations. What are the three main ways these granulomas actually damage the heart and cause problems?
Right. The presentation really depends on where those granulomas are clustering and how extensive they are. So the first way is conduction abnormalities. If the granulomas infiltrate the heart's electrical wiring, particularly the AV node or the His-Purkinje system.
You get heart block.
Exactly. Primarily things like Mobitz II second-degree block or complete third-degree heart block. That's number one. Number two is ventricular arrhythmias. If the granulomas cause scarring and inflammation within the main pumping chambers, the ventricles, it creates irritable spots and disrupts the normal electrical flow. This can lead to dangerous fast heart rhythms like ventricular tachycardia or VT, which is the main mechanism behind sudden cardiac death in these patients.
Okay, conduction block, dangerous arrhythmias. But what's the third?
The third is heart failure. If the granulomas are widespread, replacing significant amounts of healthy heart muscle with inflammatory tissue or scar, the heart simply can't pump effectively anymore. This leads to systolic dysfunction, a weak pump affecting either the left ventricle, the right ventricle, or both.
And the source mentioned that when patients do have manifest CS, their cardiac symptoms often really dominate the picture, even if they have sarcoidosis elsewhere.
Absolutely. These patients are usually highly symptomatic. They might feel dizzy or faint from the heart block, experience palpitations or near fainting from VT, or get short of breath and fatigued from the heart failure. Even if they have some mild lung stuff going on, it's often the cardiac issues, the threat of fainting, the debilitating heart failure that really drives their clinical presentation and brings them to medical attention.
Given how severe these manifestations can be, let's talk prognosis. For someone with clinically manifest CS, what's the single most critical factor that predicts their long-term survival?
Overwhelmingly, the evidence points to the extent of left ventricular dysfunction, or LV dysfunction. Basically, how weak is the main pumping chamber?
So the ejection fraction, the LVEF.
Precisely. The LVES is key. The review cites some older data, but the message is starkly clear. Patients who managed to maintain a normal ejection fraction had excellent long-term survival, close to 100% alive at 10 years in one study.
Okay, that's good news if the muscle is strong.
But contrast that with patients who had severe dysfunction defined in that study as an EF below 30%. Their 10-year survival plummeted to only 19%.
Wow, less than 1 in 5. That LVEF number really draws a line in the sand, doesn't it?
It really does. Now, we should acknowledge, as the source does, that our modern heart failure treatments and device therapies have likely improved those numbers somewhat today. But the fundamental principle holds. The amount of damage to the LV muscle is the major driver of risk in manifest CS.
It sets that baseline risk. Okay, but now we get to the really controversial part, the area where the experts really seem to disagree, and that's the outcome for patients with clinically silent CS.
Ah, yes. This is maybe the most challenging aspect of managing this disease right now. These are the people we talked about earlier, that 20-25% who have asymptomatic damage, usually picked up on advanced imaging like an MRI showing scar.
This feels like a real aha moment for anyone learning about this. The fact that the science is genuinely split on whether finding the silent damage means you need to intervene aggressively.
It's a critical clinical dilemma. The source paper summarizes the conflicting reports really well. On one hand, you have 5 separate studies involving nearly 300 patients combined that suggested a completely benign course.
Benign, meaning no problem.
Essentially, yes. These patients had SCAR, what we call late gadolinium enhancement, or LGE, on their cardiac MRI, but they experienced 0 major cardiac events, no deaths, no VT, no needed shocks, over an average follow-up of almost 2 years. The implication there is, well, maybe if it's silent, you can just watch and wait.
That sounds encouraging, actually. Less intervention is usually better if it's safe. But then you mentioned conflicting data.
Right. The pendulum swings violently the other way, because then you have 3 other significant studies reporting completely different findings. These studies showed really high rates of cardiac events. We're talking sudden death, aborted sudden death, appropriate shocks from an implanted defibrillator rates as high as 26% to 28.2% in patients who simply had that silent LGE scar.
Wait, let me make sure I heard that right. In one set of studies, 0 events over 2 years. In another set, over a quarter of asymptomatic patients with SCAR had life-threatening events. How can the data be so diametrically opposed on such a vital question?
That is the central, burning, unresolved question. And clinically, it puts doctors in a really tough spot. Imagine reading those contradictory studies. What could explain the difference? Maybe it's different patient populations, genetic backgrounds perhaps. Maybe it's the type of scar was the benign group, just old inactive scar, while the high-risk group had ongoing smoldering inflammation that wasn't fully assessed.
So maybe it's not just the presence of SCAR, the LGE, but whether there's active inflammation, something you'd see on a PET scan, happening in or around that scar that predicts the risk.
That's a leading hypothesis. Is the scar alone dangerous, or do you need that active inflammation adding fuel to the fire? It's crucial, because if you believe the benign course studies, you spare potentially thousands of asymptomatic patients from toxic steroid therapy and maybe unnecessary devices. But if you believe the high-risk studies, you absolutely must treat aggressively, potentially putting defibrillators in people who feel perfectly fine, just to manage that roughly 1 in 4 risk of sudden death.
So resolving this controversy about silent CS prognosis is, well, it sounds absolutely critical for creating clear guidelines.
It's paramount. Until we have a clearer answer, every time we find silent LGE on an MRI, it triggers a high-stakes clinical debate about risk versus benefit.
Okay, the importance of diagnosis is crystal clear now, especially finding that silent disease, which the basic tools often miss. Let's walk through the whole diagnostic toolkit, starting with the initial, simpler screening methods.
Right, so if someone already has a diagnosis of sarcoidosis elsewhere, say in the lungs, chest imaging is usually helpful. A standard chest x-ray is abnormal in a huge percentage, maybe 85–95% of those cases. High-resolution CT is even more sensitive.
But can a normal chest CT rule out heart involvement?
That's the key limitation. The source is quite clear. While an abnormal CT supports systemic sarcoidosis, a negative CT doesn't reliably exclude cardiac sarcoidosis if the patient has suspicious cardiac symptoms like unexplained heart block or VT. You just can't hang your hat on a clear chest CT to rule out CS.
Okay, moving on to the heart's electrical activity, the ECG, or electrocardiogram. We know it's often abnormal in manifest disease, showing those conduction blocks or maybe Q waves that look like an old heart attack. But what about the silent cases we're worried about?
Yeah, this is where the standard ECG really falls short in finding the hidden threat. In patients with clinically silent CS, the ECG is abnormal only in a very small percentage, maybe 3% to 8% or so.
So a normal ECG means almost nothing in terms of reassurance.
Pretty much nothing, unfortunately. However, there is one specific ECG finding that keeps popping up consistently across CS studies, and it's quite telling. Right bundle branch block, RBBB. It's reported much more commonly than left bundle branch block in CS patients.
RBBB specifically. Why the right side? Does that tell us something about where the granulomas like to form?
It's actually a huge clue about the disease's preferred location, its predilection. The granulomas seem to have this tendency to infiltrate the base of the heart, particularly the upper part of the wall between the ventricles, the basal septum.
Right.
And running right through that area is the heart's conduction system, including the bundle of His and, crucially, the right bundle branch, which is often anatomically more vulnerable there. So when granulomas form and swell in that specific spot, they often hit the right-sided pathway first, causing RBBB. Seeing unexplained RBBB, especially in a younger person, should definitely make you think about CS.
Interesting. Okay, next up, the ultrasound of the heart, echocardiography or echo.
Echo is the workhorse, right? We use it all the time. But again, for CS, its findings can be pretty nonspecific or even completely normal, especially in silent disease.
So what might you see if it's manifest?
Well, you might see the consequences, like poor LV or RV function. But there are a few more specific, though subtle, clues to look for. Things like isolated areas of the heart wall not moving well, but in a pattern that doesn't fit with a blocked coronary artery, a non-coronary distribution. You might also see unusual thinning of that basal septum we just talked about. Or sometimes, paradoxically, the wall might look thicker, potentially mimicking another condition called hypertrophic cardiomyopathy.
So echo helps, but it's not definitive, especially for catching early or subtle disease, which naturally leads us to the advanced imaging techniques. The source calls these the real game changers over the last decade or so. Let's start with the one that shows us the damage, the scar. Cardiac magnetic resonance imaging, or CMR, with LGE.
Right. CMR with late gadolinium enhancement is essentially our map of myocardial damage, specifically fibrosis or scar tissue. Gadolinium is a contrast agent that gets trapped in scarred areas. The beauty of LGE is that it can pick up even small patches of damage long before the overall heart function starts to decline.
And for sarcoidosis, it's not just that there's scar, but the pattern of the scar that's important.
Exactly. The pattern is key. In CS, the LGE is typically described as patchy and multifocal. You see multiple spots of scar scattered around, often not confined to one specific coronary artery territory.
And you mentioned a crucial difference compared to scar from a typical heart attack.
Yes, this is a really important distinction for diagnosis. It's the sparing of the endocardial border. Think of the heart wall in layers: inner endocardium, middle mid-myocardium, outer epicardium. Scar from a blocked artery, ischemic scar, usually starts right at the inner layer, the endocardium, and works its way out. Sarcoid scar, however, tends to be located in the middle layer, midwall, or the outer layer, epicardial, especially, again, in those basal segments of the septum and the lateral wall. It often completely spares that inner endocardial lining. Seeing midwall or epicardial LGE that skips the endocardium, that's a very strong clue pointing away from coronary disease and towards an inflammatory cause like sarcoidosis.
Okay, so CMR with LGE gives us the map of the chronic damage, the scar. But as we discussed in the prognosis section, knowing if the disease is currently active, if there's ongoing inflammation, is critical, especially for treatment decisions. That requires a different tool, right? Fluorodeoxyglucose, positron emission tomography, or FDG-PT.
Precisely. FDG-PT is our metabolic map. It shows us where the disease is currently hot or active. We use FDG, which is basically radio-labeled glucose.
Sugar, essentially.
Yeah, sugar analog. And the key is that those active inflammatory cells within the granulomas, particularly the activated macrophages, are incredibly metabolically active. They gobble up glucose at a much higher rate than surrounding healthy tissue. So if the PT scan lights up with specific focal areas of FDG uptake in the heart muscle, that's considered strong evidence of active inflammation and active CS.
That sounds pretty straightforward, but the source really emphasized a crucial technical aspect, preparing the patient correctly. Why is suppressing the heart's normal glucose uptake so vital for getting a good PT scan?
This is probably the most critical technical point for getting an accurate PE scan for CS. The problem is, your healthy heart muscle also uses glucose for energy under normal conditions. If you just inject FDG without proper prep, the entire heart muscle might light up brightly from this normal physiological uptake.
And that would hide the small spots of inflammation.
Exactly. It completely masks the focal pathological uptake from the granulomas that we're trying to detect. So, to get a diagnostic scan, the patient has to follow a really strict preparation protocol. This usually involves a high-fat, low-carbohydrate, no-sugar diet for at least 24 hours, sometimes longer, often combined with a period of fasting and maybe even a heparin injection right before the scan.
You're basically forcing the normal heart muscle to switch its fuel source from glucose to fatty acids.
Precisely. You suppress the background physiological uptake. This makes the abnormal focal uptake in the inflamed granulomas stand out clearly against a quiet background. It's the difference between an uninterpretable scan and a scan that can definitively show active disease.
You got it. And now technology allows combining these, right? Fused PTCMR.
Yes, that's the cutting edge. Fused PTCR scanners allow you to acquire both sets of images almost simultaneously and overlay them perfectly. So in one go, you get both maps. The PET showing the active hot inflammation and the CMR showing the chronic cold scar. You can see exactly where the active disease is located in relation to the existing damage. It gives you the most complete picture of both the current threat and the long-term structural changes.
Okay, so we have these incredibly powerful imaging tools.
Yeah.
But the absolute gold standard for diagnosis is still getting a piece of tissue, right? An endomyocardial biopsy. The source mentioned, though, that the traditional blind biopsy has a really low success rate.
Yeah, historically, the sensitivity of blind endomyocardial biopsy for CS is disappointingly low, often quoted as less than 25% positive, maybe even lower.
Why so low?
Because the disease is so patchy, the granulomas are often small and scattered. Taking a few tiny random samples from the right ventricle, which is the standard approach, is basically a lottery. You're hoping you just happen to hit one of those small islands of disease in a big ocean of normal tissue.
So how do we make biopsy more useful? Is it still worth doing?
It can be, but not the blind way. The current consensus guidelines strongly recommend moving towards image-guided biopsy. This means using the information from the PET or CMR scan to direct the biopsy tool specifically to the areas that looked abnormal on the imaging. Or, alternatively, using electrophysiological mapping during a procedure to identify areas with low voltage signals, which often correspond to scar or inflammation, and targeting those areas.
And does that targeted approach actually improve the hit rate?
Significantly. Studies suggest that image-guided or EP-guided biopsies can increase the diagnostic yield quite dramatically, potentially up to 50% or even higher in some reports.
Yeah.
It turns the biopsy from a random sampling into a much more focused investigation. It makes it a viable option, especially when the imaging findings are maybe suggestive but not entirely definitive.
Okay, this all leads nicely into the formal diagnostic criteria laid out in those 2014 consensus guidelines. It sounds like they synthesized all this, the clinical picture, the imaging, the potential for biopsy. What are the main ways someone gets an official diagnosis of CS according to those guidelines?
They essentially created two main pathways to diagnosis. Pathway number one is the gold standard, the histological diagnosis. This requires finding those characteristic non-caseating granulomas directly on a sample of heart tissue obtained via biopsy and making sure there's no other plausible explanation for those granulomas.
But given how hard it can be to get that positive biopsy.
Right. Pathway number two, which is used much more commonly in clinical practice, is the clinical diagnosis, sometimes called probable CS. This pathway doesn't require a positive heart biopsy.
What does it require then?
It has two main components. First, you need a histological diagnosis of sarcoidosis confirmed somewhere else in the body, like the lungs, lymph nodes, skin, whatever. So you know the person definitely has sarcoidosis systemically.
Okay, proof of systemic sarcoidosis.
Plus one or more specific cardiac findings that can't be readily explained by anything else. And these findings are quite specific, drawing on everything we've discussed. Things like significant LV dysfunction, an EF below 40%, experiencing sustained ventricular tachycardia, having high-grade heart block, Mobitz 2 or third degree, or having those characteristic abnormal findings on advanced imaging, either the patchy uptake on FDG PET suggesting inflammation, or the typical LGE pattern on CMR indicating scar. It's about combining the systemic diagnosis with objective evidence of otherwise unexplained cardiac involvement.
All right, so we've navigated the tricky path to diagnosis. Now, how do we manage it? For almost any active inflammatory disease, the cornerstone of treatment is usually immunosuppression, typically corticosteroids. But the source highlights a pretty major issue here, a real lack of solid proof that they actually work in sarcoidosis, especially CS.
Yeah, this is, frankly, a bit of an uncomfortable truth in the field. Corticosteroids, like prednisone, have been the mainstay for treating systemic sarcoidosis for, well, over 50 years. Yet, astonishingly, there's still no definitive proof from large randomized controlled trials, RCTs, that they actually improve survival even in the more common pulmonary form of the disease.
No RCT proof of survival benefit after 50 years.
It's quite remarkable. And for cardiac sarcoidosis specifically, the evidence base is even weaker. Most of the data we have comes from observational studies, retrospective analyses, case series. There are simply no randomized controlled trials specifically looking at steroid efficacy in CS.
That feels like a huge evidence gap for treating such a serious condition. So, if the high-quality proof is missing, why do most experts still recommend using steroids, often quite aggressively?
It really comes down to clinical experience, observational data, and a consensus based on the presumed pathophysiology. The strong belief is that suppressing the active inflammation shown on PP scans, for example, is crucial to prevent further irreversible scar formation and stop the decline in heart function or worsening of arrhythmias.
So, the thinking is, the potential benefit of stopping the inflammation outweighs the lack of RCT proof and the known side effects of steroids.
Essentially, yes. The consensus is that the risk of letting active cardiac inflammation continue unchecked is likely far greater than the risks associated with steroid therapy, especially in patients with manifest disease, those with heart block, VT, or heart failure. So yes, despite the evidence gap, most experts do recommend corticosteroid therapy for active, clinically significant CS.
Okay, for someone learning about this, let's get practical. What does that typical steroid treatment protocol look like according to the guidelines or common practice?
Dosing.
Duration.
It usually starts with a fairly high induction dose to quickly gain control of the inflammation, often something like 30 to 40 milligrams of prednisone per day, or maybe weight-based dosing around 0.5 milligram per kilogram per day, usually capped at 40 milligrams.
And how long do you stay on that high dose?
Typically for the first 1 to 3 months. The key is then to reevaluate the patient's response, often using a repeat PET scan to see if the inflammation has cooled down. If there's been a good response, meaning the FDG uptake has significantly decreased or disappeared, then the steroid dose is gradually tapered down to a lower maintenance level.
A maintenance dose. How low and for how long?
The maintenance dose is usually in the range of 5 to 15 milligrams per day, and the guidelines generally suggest continuing this lower dose for quite a while, typically for an additional 9 to 12 months. The goal is often a total treatment duration of at least 12 months for the initial course.
A full year of treatment, even if the inflammation seems gone after a few months.
Yes, the concern is relapse if you stop too soon. And even after completing that year, the story isn't necessarily over. The risk of the inflammation coming back or relapsing is significant. So the guidelines recommend close follow-up for at least 3 years after stopping the initial steroid therapy.
Wow, long-term commitment. What if steroids don't work or the side effects are too severe? Are there other options?
Absolutely. If the disease is refractory to steroids, or if the patient develops significant side effects like diabetes or osteoporosis, then second-line immunosuppressants are considered. The most commonly used agent is typically methotrexate. After that, options might include azathioprine, mycophenolate mofetil, and in very difficult cases, more potent drugs like cyclophosphamide or biologic agents like the TNF-alpha inhibitor infliximab.
Okay, let's circle back to that key prognostic factor, left ventricular function. How effective are steroids at actually improving or preserving the heart's pumping ability? Does it reverse heart failure?
The data here is a bit nuanced and again mostly observational. It seems steroids are pretty good at maintaining normal LV function if you catch the disease before the EF drops significantly.
So prevention is better than cure, in a sense.
It seems so. Steroids also appear to be reasonably effective at improving the ejection fraction in patients who present with mild to moderate LV dysfunction. They can help the stunned, inflamed muscle recover some function.
But what about severe heart failure? If the EF is already really low, say below 30%.
That's where the data gets less encouraging. Several studies cited in the review suggested that once the LV dysfunction is severe, EF 30%, steroids often show no significant improvement in ejection fraction. The thinking is that by this stage, much of the muscle has likely been replaced by irreversible scar tissue, and steroids can't undo established fibrosis. They can only fight active inflammation.
Although you mentioned there was maybe one conflicting study.
Yes, it's important to note there was at least one study mentioned that did show some improvement, even in patients with EF below 35%. So it's not entirely hopeless, but the general trend suggests less benefit once severe damage is done.
Regardless of the steroid effect, if a patient has heart failure due to CS, they still need all the standard heart failure treatments, right?
Oh, absolutely. That's non-negotiable. Immunosuppression is targeting the underlying sarcoid process, but the patient must also be on optimal medical therapy for heart failure. ACE inhibitors or ARBs, beta blockers, mineralocorticoid receptor antagonists, diuretics as needed, all the standard pillars of HF care apply. And if they progress to end-stage heart failure despite everything, they are definitely candidates for advanced therapies like mechanical support devices or even heart transplantation.
Okay, let's shift gears to managing the electrical problems, which are so common and dangerous in CS, starting with the conduction abnormalities, the heart block.
Right, because the granulomas so often hit the conduction system, the threshold for intervening with a device is very low. If a patient presents with advanced heart block, Mobitz the second degree or third degree complete heart block attributed to CS, device implantation is indicated. This usually means a permanent pacemaker, but often an ICD is chosen because of the concomitant arrhythmia risk.
Now, here's a key point the source made. What if the heart block seems to get better after you start steroids? Does that change the need for a pacemaker?
That's a critical point the guidelines emphasize. No, it doesn't change the indication. Even if the AV block transiently improves or resolves completely with immunosuppression, a permanent pacing device, pacemaker or ICD, is still recommended.
Why is that? If the inflammation is gone, isn't the block fixed?
You just can't rely on it. The inflammation might have caused permanent scarring in the conduction system, even if the acute swelling goes down. Or the inflammation could simply relapse later on. The risk of the block returning suddenly is considered too high to leave the patient unprotected. So you treat the inflammation if it's active, but you also secure the electrical backup with a device.
Got it. Now, what about the other major electrical threat, ventricular arrhythmias or VT, the cause of sudden death? How do we manage that?
VT in CS is usually thought to be caused by scar tissue. The electrical signals get caught in slow conduction zones around the areas of fibrosis, setting up re-entrant circuits. However, active inflammation can definitely act as a trigger, making these circuits more likely to activate.
So it's a combination of scar and potential inflammation.
Often, yes, which leads to a layered management approach. If the patient has VT and there's evidence of active inflammation on their PET scan, the guidelines suggest immunosuppression as a first step, often alongside standard antiarrhythmic drugs. The idea is to cool down the inflammation to make the heart less irritable and hopefully reduce the VT burden.
What if that doesn't work? What about catheter ablation?
Catheter ablation, where you try to cauterize or burn the abnormal electrical circuits, is definitely an option, but it's typically reserved for cases where VT persists despite immunosuppression and antiarrhythmic drugs.
And how successful is ablation in CS?
Unfortunately, the outcomes are often described as modest. Sarcoid scar can be very tricky to ablate. It's often patchy, deep within the muscle wall, mid-myocardial or epicardial, and sometimes there are multiple different circuits. Success rates vary, but recurrence of VT after ablation is quite common, with rates reported anywhere from 44% up to 75% in some series.
So ablation isn't usually a cure.
Often it's more about reducing the frequency of VT episodes, maybe allowing the patient to come off some high-dose antiarrhythmic drugs, rather than completely eliminating the problem. It plays a role, but it's challenging.
Okay, finally, the most critical intervention for preventing sudden death. The implantable cardioverter defibrillator, or ICD. We know CS patients are high risk. When is an ICD absolutely recommended, and when is it considered?
The 2014 guidelines provide pretty clear recommendations based largely on established criteria for other cardiomyopathies, but adapted for the specific risks of CS. There is a Class I recommendation, meaning it's considered mandatory or required for two main groups.
Okay, who are they?
First, secondary prevention. Anyone with CS who has already survived a cardiac arrest due to VT or VF, or who has experienced spontaneous sustained VT, if you've had the event, you need the protection.
Makes sense. And the second Class I group?
That's for primary prevention, based on severe structural damage. It's recommended for patients whose left ventricular ejection fraction, LVEF, remains less than or equal to 35%, despite being on optimal medical therapy for heart failure and having received an adequate trial of immunosuppression, if indicated. That low EF is considered a high-risk marker on its own.
So survived arrest VT or EF 35%. Those are the absolutes. What about the gray areas? Patients with maybe better EF but still concerning features.
Right, that falls under the Class Sky recommendation. This means implantation is considered reasonable and can be useful. The benefit likely outweighs the risk. And importantly, for this recommendation in CS, the ICD decision becomes somewhat independent of the LVEF.
Independent of EF. So what triggers a Class TII recommendation?
There are a few scenarios. One is if the patient has an indication for permanent pacing anyway, like for the heart block we discussed. Given the high risk of VT and CS, upgrading to an ICD makes sense. Another is if the patient has had unexplained syncope, fainting, that is strongly suspected to be due to an arrhythmia. And the third is if sustained VT can be induced during an electrophysiology EP study. If you can provoke the dangerous rhythm in the lab, even if their EF is preserved and they haven't fainted yet, the guidelines suggest an ICD is reasonable because of the underlying disease's known propensity for sudden death. It's about proactively managing that high electrical risk inherent to CS.
Wow, okay. This has been a really detailed look at a complex condition. Let's try to synthesize the absolute must-know points for someone trying to get a handle on cardiac sarcoidosis, connecting all these diagnostic and management pieces.
I think the first major takeaway is that CS diagnoses are definitely on the rise. But you need to remember, this is almost certainly driven by our better imaging CMR and PET, revealing the silent disease that was likely missed before. It's not necessarily more common, just better detected.
Right. And second, you absolutely have to think about CS early, and even when it seems unlikely. Remember, it can be the very first sign of sarcoidosis, sometimes completely isolated to the heart. So if you encounter a younger patient with unexplained heart block, especially RBBB or unexplained VT, CS needs to be high on your list.
Exactly. And third, when it comes to prognosis, especially in patients who do have symptoms or manifest disease, the key predictor seems to be the extent of damage to the heart muscle itself primarily, the left ventricular ejection fraction. How much has the pump weakened? That tells you a lot about long-term risk.
But we have to end, really where we started, acknowledging the big unresolved questions. We have these 2014 guidelines, which are incredibly helpful, but they're built on a foundation where, for key aspects like steroid efficacy, we still lack that definitive RCT evidence. And that huge controversy over the prognosis of clinically silent CS still looms large.
It really does, and that leads directly into the critical knowledge gaps that the authors of this review highlighted. What do we still desperately need to figure out to improve care for these patients?
What are the top priorities according to the source?
Well, first we need to nail down the optimal screening strategy. What's the best, most cost-effective combination of tests, ECG, echo, maybe biomarkers, maybe targeted imaging to reliably pick up silent CS in patients with known systemic sarcoidosis, or even in those high-risk groups presenting with unexplained arrhythmias? We need better sensitivity and specificity data for screening protocols.
Okay, better screening. What else?
Second, what about follow-up? If someone has systemic sarcoidosis but their initial cardiac workup is completely negative, are they cleared forever? Or do they need interval rescreening? The disease can develop insidiously over years. We currently have no clear guidance on whether or how often to relook for cardiac involvement after an initial negative screen.
Right, that's a big practical question. And the third gap?
The third, and arguably the most impactful, is resolving that fundamental controversy we keep coming back to, the prognosis of clinically silent CS. We absolutely must get a clear answer. Does finding that patch of LGE scar on an MRI in an asymptomatic patient automatically put them in a high-risk category requiring aggressive management? Or is the risk mainly confined to those who also have active inflammation on PET or whose LV function starts to decline?
Getting that risk stratification right seems paramount.
It changes everything, because the answer determines whether we potentially subject hundreds of thousands of people worldwide who feel perfectly fine to long-term immunosuppression and costly ICDs, or whether a more conservative watch-and-wait approach is safe for many of them. Clarifying that risk is probably the single biggest unmet need in the field right now.
It really underscores the whole message, doesn't it? Sarcoidosis might seem relatively manageable when it's just in the lungs or skin, but as the source emphasizes, once it involves the heart, the stakes are just dramatically higher. That hidden risk of sudden cardiac death transforms the clinical picture, and it highlights why that advanced cardiac imaging, the CMR, to see the scar, the PET, to see the fire, is so incredibly critical. It seems like it's often the only way to truly map out the unseen danger and make informed decisions about how to protect the patient. Thank you for watching The Funnel Effect.